All right, welcome to The Explainer. Today, we're diving deep into what is really the heart of any surgery, the maintenance of anesthesia. This is where the art and science of anesthesia truly come together, and you can bet it's a huge topic for your final exams. So let's jump right in. Okay, so here's our game plan for today. We're going to start with the basics. What are we even trying to do? Then, we'll open up the anesthetist's toolbox and look at the drugs we use. From there, we'll tackle that really tricky transition period, cover the essentials of keeping things safe, and finally, we'll talk about monitoring the patient to make sure they are, in fact, safely anesthetized. So, first things first, before we get into all the cool pharmacology and physiology, we've got to be crystal clear on the what. What is our number one objective during this maintenance phase? This definition right here is everything. We are creating this profound, controlled state where the patient is totally unaware and doesn't react to pain. But honestly, the most important word on this whole slide is reversible. Our job is to keep the patient perfectly stable in this state for the exact length of the surgery, and not a moment longer. You know, you can think of any general anesthesia like a 3-act play. Act 1 is induction. That's getting the patient off to sleep. Act 3 is emergence, waking them up at the end. But today we are laser-focused on Act 2, maintenance. This is the long, steady middle part of the story where our vigilance is absolutely everything. So how do we actually do this? What's in our toolbox? Well, to keep a patient anesthetized, we basically have two main highways we can go down. You can deliver the drugs through the air they breathe, or you can send them straight into their veins. You're going to need to know both, inside and out. It really boils down to two main routes. The first, and maybe the most common, is inhalational anesthesia. The anesthetic agent is turned into a gas that the patient breathes in. The second is total intravenous anesthesia. You'll hear it called TIVA, and that's where we infuse the drugs directly through an IV line. Let's tackle the inhaled agents first. So with the inhalational route, we use these things called volatile agents. They're liquids that our anesthetic machine turns into a very precise vapor. The big three you're going to see and use every single day are sevoflurane, isoflurane, and desflurane. These are the absolute workhorses of modern anesthesia. Whoa, okay, this table looks like a lot, I know. But don't panic, you really only need to focus on two key columns here to understand how these drugs work. First, look at blood gas. Think of that as the drug's speed dial. A low number, like you see for desflurane, means it's super fast on and super fast off. Then look at oil gas. That's your potency meter. Let's see how that ties into our next big concept. And that brings us to MAC, which stands for minimum alveolar concentration. This is like the universal measuring stick for how potent an inhaled drug is. It's tied directly to that oil to gas number we just saw, but here's the catch. It's an inverse relationship. So the big takeaway, the thing you have to remember for your exams is this. A low MAC means it's a highly potent drug. You need less of it to get the job done. Now this is absolutely crucial. MAC is not some fixed, magical number. It's a starting point. It's an average for the population. You have to tweak it for every single patient. And this slide, this is a guaranteed exam question, so listen up. The rule of thumb is simple. Things that speed up the body's metabolism, like being young or having a fever, will increase the MAC you need. And things that slow metabolism down, like older age or being cold, will decrease it. Okay, let's switch gears and talk about TIVA. With TIVA, we're using a continuous infusion of drugs through an IV. Now, the magic behind TIVA is all about this fancy-sounding term, context-sensitive halftime. It sounds complicated, but the concept is simple. It just means that no matter how long that infusion has been running, whether it's 30 minutes or 5 hours, when you turn it off, the drug wears off quickly and predictably. And that gives us phenomenal control. So for TIVA, the dream team, the classic combo is propofol for the hypnosis, the sleep, and an opioid like remifentanil for the powerful pain relief. They have this amazing synergistic effect. There's also a newer drug on the scene, dexmedetomidine, which is cool because you can add it in to reduce how much of the other two you need, and it has this fantastic side effect of not suppressing breathing very much. So how in the world does a TIVA pump know how much drug to give? Well, it's pretty clever. It uses what we call a 3-compartment model. Just picture this. Imagine you're pouring the drug into a central bucket. That's the blood. And that bucket has pipes leading out to 2 other buckets. A small one that fills up fast, that's like our muscle, and a huge one that fills up really slowly, like our body fat. The pump's computer is constantly doing math to figure out how the drug is moving between all these buckets to keep the level in the brain perfectly steady.
All right, now let's talk about one of the riskiest, most high-stakes moments in any anesthetic, and that's the handoff. I'm talking about those critical couple of minutes when you're switching from the IV drug you used for induction to the inhaled gas you're going to use for maintenance.
So what is it? What's the number one danger we're trying to dodge here? Well, the answer is a dangerous gap in our anesthetic cover, which can lead to one of the complications we fear most.
It's this terrifying little gap we call the window of awareness. Picture a graph in your head. You've got one line going down, that's the IV induction drug wearing off. And at the same time, you got another line going up, that's the inhaled gas slowly building up in the brain. If a big stimulus, like intubation, happens right in that dip in the middle, where neither drug is at full strength, well, that's when the patient could become aware.
Okay, deep breath. We've made it through the transition. Now we're in the steady state of maintenance. Our job description kind of changes now. We're moving from just getting the patient anesthetized to keeping them physiologically safe and sound for the rest of the surgery. This slide is basically our core checklist during maintenance. We are constantly juggling the patient's breathing, their blood pressure, their fluids, and their temperature. You can really think of these as the 4 pillars that are holding your patient up safely throughout the entire surgery. If any one of them starts to look wobbly, we have to jump in right away. And that brings us to the big one, the million-dollar question, really. How do we know? How can we be 100% sure that our patient is actually unconscious? You might think, easy, just give them 1 MAC of gas, right? But remember what we said, MAC is just an average. It tells you what works for 50% of people, but it tells you absolutely nothing about what's going on inside the brain of the unique individual lying right there in front of you. So that uncertainty led to the development of brain function monitors. The most famous one is called the bispectral index, or BIS. The idea was brilliant. You stick a few electrodes on the patient's forehead, and a computer crunches their brainwave data into a simple number from 0 to 100 to tell you how asleep they are. But here's the kicker. When they actually tested this in massive clinical trials like Be Aware and Bag Recall, the results were a huge surprise. For regular gas anesthesia, using a BIS monitor was no better at preventing awareness than just doing what we've always done, measuring the gas concentration the patient breathes out. But hold on, that doesn't mean these monitors are useless. They actually found a really important job to do, but it's specifically with TIVA. See, with an IV anesthetic, there's no gas to measure, so if your patient is also paralyzed with a muscle relaxant and can't move, how on earth do you know they're not awake? This is where a brain monitor can be a vital safety net, and the landmark 5th National Audit Project, or NAP5, basically said exactly that. They're a good idea for this very specific high-risk scenario. And really, this is the most important lesson of all. The tech is great, it's a safety net, but it is never, ever a substitute for the clinician. Just like this quote says, "Nothing beats your own sustained vigilance, your focused attention, and crystal clear communication. That has always been and will always be the bedrock of safe anesthesia." So that wraps up our tour of anesthesia maintenance. We've gone through the goals, the drugs, the critical moments, and the safety checks. I want to leave you with one final thought to chew on. In an operating room that's getting filled with more and more amazing technology, is it possible that the single most important monitor is still the anesthesiologist's own watchful eye?